Okay everyone, this is going to be the last video in your reproductive series, so I know y'all are super excited about that. This is going to be your newborn care, so obviously the care that we would teach or provide to the newborn baby. So we're going to get started. This typically does not last as long as the postpartum, so hopefully this will be a little bit of a shorter video for you guys to sit through. So here we go. All right, your initial newborn assessment. So the first assessment that we're going to perform on a newborn is going to be something called an APGAR scoring. It's a quick assessment that can guide the care of that infant in that immediate postpartum period. So for every patient, they're going to get an APGAR score at 1 minute and 5 minutes, no matter if they are perfect. So every baby gets a 1 and 5 minute APGAR score. However, if we are doing interventions or providing resuscitative measures for the infant, we're going to do those every 5 minutes until the baby is stable or until we call off the resuscitative measures and declare the baby's deceased. So we don't like to think about those things, and the good news is that doesn't happen all that often, but those are kind of the guidelines that we use as far as how often we're going to do the APGAR scoring. So I'll go ahead and tell you, I try not to pull any punches when I talk about testing and that kind of thing. You will have APGAR scoring on your test, so it is your responsibility to kind of memorize this scale or at least have some indication. So the two ways that I would typically ask an APGAR scoring question is to ask you to calculate what the APGAR score would be for a baby given the certain criteria or what information I give you about the assessment. The second way that I could ask it is for you to be able to decide whether or not there needs to be some further intervention. So for this semester, we do not expect that you're completely proficient or that you know how to do, advanced life support measures for an infant. That's not what this semester is about. But you do need to be able to pick up a baby that's going to need further resuscitative measures or interventions. So the way this APGAR scoring system works, the APGAR is actually going to be an acronym for what you're assessing. And essentially the baby's either going to get 0, 1, or 2 points. So 0 points meaning they are not doing what they're supposed to. 1 point meaning they're doing it a little bit, but not to the level they should be. And then 2 means they're doing it appropriately. So if you kind of think about that. So A is for activity, P is for pulse, G is for grimace, A is for appearance or color, and then R is for respiration. So the two that give students the most trouble are going to be activity and grimace, and they almost always go hand in hand. So if you have a baby that's actively moving, they also demonstrate grimace. So when you see that, those two tend to go hand in hand. So if they have active movement, they're going to get a 2 for activity and for grimace. Okay? For your pulse, your normal pulse is going to be 110 to 160. We give them a little bit of a leeway on that during your APGAR scoring. So if it's over 100, they're going to get 2 points. If it's below 100 but still there, they get 1. And if they have no pulse, they're going to get a 0. For your activity and your grimace, if they are actively moving, they're going to get a 2. If they have some flexion of just their extremities but they're not actively moving, they get a 1. And if they are flaccid and have no activity or no movement, that is going to be a 0 for both of those. For your appearance, if they are completely pink, they get a 2. That is very uncommon for a baby to be born and be completely pink, so very few babies get a perfect score of 10 because of their color. Most of your babies are going to get counted off for color because even though their body or their trunk is nice and pink, they're going to have these little bluish colored hands and feet. That is a term called acrocyanosis, and it's not really problematic, but we do count off for it because it is not a completely normal finding. So acrocyanosis is expected in that early postpartum period. It's almost like you have to remember that this baby just came out of a uterus where mom was taking care of everything. Mom was oxygenating the baby, it was taking care of removing the waste products, and then they're born and they have to start to take over all those functions. So it takes them a little bit to get the hang of perfusing everything. So acrocyanosis, little blue hands and feet, that's okay. If they are completely blue or pale, meaning that their overall skin color is blue or pale, they're going to get a 0. For respirations, if they are crying, they are breathing just fine. But if you look at the normal respiratory rate, it is higher for an infant, so 30 to 60 is considered normal. So you could also have a respiratory rate of 50 that would be considered normal, and they would get a 2 for that. If it's slow or irregular, so if it's irregular and slow, so less than 30 breaths per minute, that's going to give them a 1. And if they have no respiratory effort, that's going to be a 0. So you can kind of figure out just by looking at this, the lower the score, the more interventions we're going to have to do. So typically we consider, most hospitals like to see APGAR scorings of 8 to 10. But 7 to 10 is kind of going to be in that range where you can do expected management or, just do your routine care. If it's less than 7, then there's going to be some type of interventions that we're doing, whether we're doing chest compressions or providing ventilations or providing some supplemental oxygen. So anything less than 7, you're going to see some type of intervention. What you should know, just as a kind of a general rule, is that in your infants and your pediatrics too, usually if they're going to suffer a cardiac arrest or have a cardiac, like a bradycardia, it's going to be preempted by a respiratory issue. So for your infants, it's almost always going to be an airway issue. So we are going to clear their airway. We're going to make sure we're ventilating them, and that usually takes care of their heart rate. So APGAR scoring, 1 in 5 minutes for everybody. Anything less than 7 needs a definite intervention. Anything over 7, they can continue what we consider their expected care or just the normal nursing actions that we would find. So I am going to go over an APGAR score with you, and we're going to see if we get the same answer. So at 1 minute following delivery, you note the following assessment findings. So they have a vigorous cry, so that's going to give them a 2 for respirations. They have acrocyanosis, so that's going to give them a 1 for color. They have active movement, so that's going to give them a 2 for activity and a 2 for grimace. And they have a pulse rate of 136, which is going to be over 100, so they're going to get a 2 for that one as well. So the only thing that we're counting off for is the acrocyanosis, so that would give them a score of 9. So if I ask you on a test question, I could say, what is your APGAR score? And you would plug in 9, or you would pick the answer that says 9. Or I could say, you have these findings, what is the best nursing action? So you're going to pick the one that says, do the normal stuff, whatever that happens to be. Continue with weights and measurements, or place the infant skin to skin, those normal things that we would do. What you wouldn't select would be, give them supplemental oxygen, or start to ventilate the baby, or perform chest compressions, because those things aren't needed. So just some basic understanding. I don't expect that you know all about neonatal resuscitation. That's not the plan for this semester. Once we've established their APGAR score and we determine that the infant is stable as of this particular moment, then this is going to be the expected management or the normal care that you would see us do. So one of the first things that we're going to do is to ensure security of the baby. So initially they're going to get a band that has their name on it, or has their mom's name on it. So you see that in the left bottom corner. They also get we lovingly refer to it as our baby low jack system, but it goes on their ankle, and essentially it's going to alarm if that baby gets near any exit door. So that's kind of a safety feature for us, and it's a security feature for the parents, so they know we are taking their infant's security very seriously. We would like to think that nobody's going to try to steal a baby, but that's just not the reality that we live in, so we want to make sure that we're doing everything that we can. Additionally, in addition to those safety measures that we implement, your labor and delivery nursery units are going to be completely locked down units, meaning there's one way for traffic to get in for labor and delivery and nursery. There's usually a security door that has to be buzzed in by staff, and that's just an added way that we make sure we keep our babies safe. So that's very, very, very important. The other thing that we do is, if any of your hospitals, it may be different as to how they look, but all hospitals are going to have something on their nurse's name badge that designates them to the maternal infant services portion of the hospital. So ours have a pink stripe on it, and so we tell our patients when they come in, nobody takes your baby unless they have this pink stripe on their name badge that shows that they do work in that particular unit. So once we've done the security measurements or security things, we're going to go ahead and do the normal medications that you would give an infant. So vitamin K is going to be state mandated to be given. It is an IM injection, and it helps their blood to clot. So vitamin K is synthesized in the gut, but a baby has never eaten, so their gut is sterile, so they can't synthesize their own vitamin K until they start eating, so they're higher risk for bleeding. So because of that, we give them a vitamin K injection, which gets them a little bit of a booster on that so they don't have bleeding issues. So that's what the vitamin K is given for. A lot of times if patients are wanting to refuse that, it just kind of requires some education, because we live in a society now where vaccinations aren't always viewed as a positive thing, and so some patients get really confused as to why we would be giving them vitamin K. So usually with some education on why we give it, that one is not one that we have a lot of parents decline, and there would be extra paperwork if they were adamant they did not want the baby to get the vitamin K. The hepatitis B vaccination, however, is going to be dependent on whether or not the parent wants it. So the hepatitis B vaccination is one of the childhood immunizations. It is a series, just like it was for you guys if you didn't get it when you were kids and you got it coming into nursing school. So they do require that before they start school, but it is not required that the first shot is started in the hospital. So it is okay if the parents want to decline that one and give it at their first well visit or discuss that with a physician. So that one is not mandatory. It is, however, an IM injection. So for your vitamin K and your hepatitis B, your site of choice for your infant is going to be the vastus lateralis. Make sure you go back and know what size and gauge needles you would use. So basically a little needle. So the higher the number on the gauge, the smaller the needle. So it would be appropriate to use a 25 gauge, and you're also going to want a fairly short needle, so 3/8 to 5/8 inch, depending on the size of your baby, would be appropriate needle gauges and sizes for them. You're going to give it in the vastus lateralis, and you're going to, if they're getting both of them, you give one in each leg, and you would document which leg you gave that one in, because that way if they have a reaction, we know which one was given in what leg. The other medication that is required for infants is going to be an eye ointment. Most hospitals use an erythromycin, so you see it there. It is a metal tube, so just be mindful of that. The eye ointment is state mandated, so again, if the parents are just adamant they're going to refuse, there's a lot of extra paperwork we have to do for that. But what we give this for is to prevent any infection of the baby's eyes from passing through the vaginal canal. Now, even a patient that has a C-section, we give this, so every baby's going to get it. We don't go in and tell the mom, well, we're giving this because you probably have an STI. That's not how we approach that. We just tell them that it's given to all babies to prevent any infection in their eyes, and just kind of leave it at that. If they want to refuse it again, we'd have to do some extra paperwork, but that's not one that we usually have issues with parents refusing. Once we've done that, then we're going to go ahead and do weights and measurements. So weight, obviously, to weigh the baby to see how many pounds and ounces, because that's something that the parents want to record and know for their records. Then we're going to do measurements. So all babies are going to get a head circumference, a chest circumference, and a length measurement. So the head circumference is going to be measured at the brow line. That's the widest part of the fetal head, or the infant head now. The chest measurement is going to be at the nipple line. And those two measurements should correlate with each other. So you shouldn't have an infant that has a 16 centimeter head measurement and a 12 centimeter chest measurement. Those two measurements should correlate pretty well with each other. For the length, you're going to do tip of the head to an outstretched heel, as shown in the picture there. If they are cone-headed because they spent some time trying to mold their way through the vaginal canal, it's okay. They can be, they'll shrink tomorrow, but that's okay. You're going to do from the tip of the head to an outstretched heel. And those are measurements that all of your babies are going to get. The additional one that's shown in that picture is going to be an abdominal circumference. It is not a routine measurement, but it is usually done with your premature babies. The advantage to doing an abdominal circumference is should the baby start to have abdominal distension, you would have an objective way to measure that. Your little bitty premature babies tend to have more GI issues, and so they tend to do an abdominal circumference on them so they have a baseline. So essentially it's going to be measured at the umbilicus, and that can be done every day or every so often to determine if there's abdominal distension, if that's something that we're concerned about. They will also get a once-over just to kind of make sure there's no obvious abnormalities that we can see. So for instance, during this period, if we had a mom that came in and let's say that she was 40 years old, she had no prenatal care, there are some telltale signs that we can see, maybe that the baby has Down syndrome or some abnormalities that we could look for. And that's part of your growth and development lecture, and we'll talk a little bit about that, like some of the signs and symptoms that you would notice at birth that would kind of key us in that there's a problem. They typically also will do a once-over to make sure there's no, big or large abnormalities like spina bifida. Those are usually very apparent at birth. So any just general appearance changes or things that need to be reported, we would go ahead and do that. Somewhere between 1 to 2 hours post-delivery. So assuming that we get all that stuff done on the previous slide, it's completely okay for that baby to go and love on its mama because they've both worked hard today and they need to get skin to skin. So the soon as we can get that baby skin to skin, meaning nothing but a diaper on mom's chest, and then we can cover mom with a blanket or with her gown, skin to skin is going to be hugely important because it is tremendously beneficial to that baby. It promotes bonding, it helps with breastfeeding, it helps with thermoregulation, it helps to prevent complications like cold stress because the mom will warm up or cool off to accommodate what that baby needs. It's pretty amazing to see. That's why your NICUs usually promote kangaroo care, skin to skin contact, because it is super, super, super beneficial for the baby and for the mom. Somewhere between 1 to 2 hours once mom's had her skin-to-skin time and we've assisted with breastfeeding and those type things, you will see the nursery staff do vital signs. So of all the vital signs, we don't typically worry as much about the blood pressure. Your babies don't tend to have blood pressure issues, but they will do a blood pressure check on them. But they will then be doing more frequent checks on respirations and heart rate and temperature to make sure that they are all within the normal range. We'll do a gestational age assessment, which we mentioned, I think, with antepartum. But the gestational age assessment is basically just the nurse assessing the neurological and physical parts of the baby to see if they are the gestational age that we thought they were. So if the prenatal record says that they are 38 weeks, then her assessment should yield findings that are consistent with that. If it doesn't, then those two things don't talk to each other. So now we know we probably have a baby that's not where it should be, and so we need to monitor them for complications. So just to kind of give you a general idea, you will get more of this when we discuss it in 211 next semester. But a premature baby is going to have more vernix, meaning it's going to be more cheesy. It's going to be more hairy with that little fine lanugo hair. They're usually more flexible. They kind of have like a sunbathing. If you lay them out on the warming table, they kind of lay out. Their little arms and legs aren't flexed like a full-term baby would be. A post-dates baby or a baby that's full-term is going to tend to have less vernix, less lanugo, and they may even have skin that's peeling on their palms and their soles of their feet, especially if their post-dates are greater than 40 weeks. So we can kind of use those things to determine whether or not we feel like they are gestationally aged appropriately based on their prenatal record. We'll do a head-to-toe assessment. We'll make sure that everything looks good, there's no heart murmurs, everything looks fine with that. And then we will also do a reflex assessment. So I do want you guys to make sure that you review your reflexes. So I'm going to give you the ones that I want you guys to kind of be familiar with. And I'll probably do that in the afternoon session. We'll kind of talk about those a little bit. Most of them are going to be the ones that that are pretty routine, the Babinski, the Morrow, the rooting reflex. Those are the major ones that you need to be familiar with. So just kind of make sure you know how to assess those. So that's going to help to determine the neurological function of the baby to make sure everything is a-okay and that they are doing what they're supposed to be doing. So that's going to be your first 1 to 2 hour assessment. Past that, then you're going to be doing more of an ongoing or routine care and assessment. So they typically do vital signs every 4 to 8 hours. We do now kind of prolong or delay, I guess is the better way to put that, their first bath. So we used to try to bathe them within the first hour or two, but the new recommendations are to delay that first bath for a little bit longer. So some of your hospitals may delay that even up to 6 or 8 hours post-delivery. We like to at least give them a couple of hours before we do that. And it's going to sound weird, but that vernix that's in their skin, the longer we kind of let that sit on there, the more nourished their skin is. So we typically don't bathe them till at least 2 hours post-delivery, and it can't even be longer than that. But your nursing care does change a little bit based on that. So until they have their first bath, it's very important that you wear your gloves. Because just remember, that infant just passed through the vaginal canal, and essentially if you're sitting there touching the baby with bare hands, you're essentially touching vaginal secretions. So just kind of keep that in mind. So before their first bath, you will wear gloves. After their first bath, you can do your routine care of a baby without gloves on, unless there's some other reason to have to wear gloves. You also want to make sure, even within those time constraints, that the baby is warm enough to bathe. So they need to be at least 98 degrees. And we usually do axillary temperatures on the baby, so they need to be at least 98 degrees in the axillary temp to be able to receive their bath, because we know when we bathe them, they're going to tend to lose some body heat, and we do know that cold babies get into respiratory distress really easily. So we want to make sure that they're nice and warm before we give them that first bath. We're also going to go ahead and do some education about routine care, about how to diaper the baby, how to clean the baby, and all of that I'm going to go over in just a little bit. We also need to make sure that we monitor intake and output. So when the moms change a diaper, we need to know if they pooped. We can weigh their diapers to determine their urine output if needed. We want to make sure that they are urinating and they are pooping, because that's going to show us that the plumbing is working properly. So making sure that we do that. So typically, pooping and peeing usually happens within the first 24 hours. For a lot of times, it's going to happen at delivery or shortly after. When that cold air hits their genitals, they like to pee all over us, which is fine. But we do need to make sure that their plumbing is working and that they are peeing and pooping at a regular basis, because that's our way of knowing that they're happy and healthy and that they're getting the nutrition that they need. We will also do weights on an ongoing assessment. It is very common for a baby to lose a certain percentage of its body weight, but we want to make sure before we send them home that they have started regaining that. So usually, you will see a slight decrease in their weight on the second day after delivery, but then they will start to kind of inch back up and get back close to that birth weight. Some complications that you can see. So the first two, the cephalohematoma and the caput, I just want to reiterate that just so you kind of know. So caput is basically just soft tissue swelling of the baby, and it is pretty common, especially if it was a long labor or mom had to push a lot. So sometimes you can see caput, but caput will actually cross a fontanelle. So when you look at the baby, they have fontanelles and they have these plates in their head that could kind of overlap a little bit to allow them to descend through the birth canal. So your caput is kind of soft tissue swelling all the way across the fetal head, or at least over the majority of the fetal head. And that is pretty commonly seen with long labors. So that's not something that we terribly worry about. But what would be very concerning would be if they have a cephalohematoma. And so with those, it's usually unilateral. And it's obviously not going to cross a suture line. So it's not going to cross the midline of the skull. So it's going to be on one side or the other. And that is very commonly seen when we have to use vacuum, or not commonly seen, but it can be seen when we use vacuum devices to help assist the delivery of that baby. So if you have a mom and she had a baby that was delivered and we had to use some type of vacuum assistive device to help that delivery, then we need to make sure that we're monitoring that fetal head very closely for what would look like a big hematoma on the head that doesn't cross a suture line. So it's going to look more bruised, whereas the caput's just going to look like just regular swelling kind of thing. We also want to check the patients for congenital hip dislocation. So that picture on the right hand side shows you kind of one of the telltale signs that they may have a hip issue. You can see how they have uneven skin folds, and they will do some maneuvering of that hip to see if it's popping out of socket, and so there's some intervention. So if you ever notice that they're having uneven skin folds, that's something that needs to be followed up to determine if they have a congenital hip dislocation, because that patient is going to require some different things that are going to be ongoing when they go home. So we want to make sure that we report that to the healthcare provider. If you have a baby that's premature, we're not going to spend tons of time on that this semester. That's more for next semester. But I do want you to know that if you have a baby that's premature, the biggest complication that we see is respiratory distress. So it's very important if that baby's born early that we are providing a very good respiratory assessment, because that is usually what gives us the most issue. We also want to look for hypoglycemia, which I have a slide on that coming up. So we'll talk about that in a couple minutes as well. Another thing that you can see with your babies is jaundice. It's not normal, but it is pretty common. But I do want to classify the two different types of jaundice. So pathological jaundice versus physiological jaundice. So pathological jaundice is usually going to be present within the first 24 hours, meaning there was something going on inside mom that was causing, or inside the baby, that was causing jaundice before they were born. So a lot of pathological jaundice patients are born and they are already having jaundice. So if they develop jaundice within the first 24 hours, that is considered pathological. It is not a normal finding, and we need to investigate to see what the cause is. So to give you kind of a frame of reference how all this kind of plays into each other, when we talked about in antepartum the importance of a negative blood type mom for getting RhoGAM because it protects a subsequent or a later pregnancy, this is one of the reasons why. If mom did not get a RhoGAM shot with a previous pregnancy, then it can start to attack that baby, and one of the typical symptoms that we see is pathological jaundice because it was actually attacking that baby. So just kind of keep in mind that. However, jaundice that is found after 24 hours of life is pretty common and pretty easily treated. So your physiological jaundice is going to appear after 24 hours of life. We consider it more of your normal jaundice, and we're just going to treat it. I'm not going to ask that you know the levels. Just know that if they have high levels of bilirubin and they have that yellowish color to their skin, they are considered jaundice, but I am going to talk about the treatment of that. So we want to increase breastfeeding, will help if they're breastfeeding. We can place them under UV light, so that could be sunlight. So if it's a minor case, it may be sit your baby in the car seat in front of the window and allow them to get some UV light from that area. However, if it is more severe or we don't have access to that or it's not safe to do that, then we can do Billy lights. So the two bottom pictures are different types of Billy lights. So the one on the left is probably the most common. It's kind of an It's kind of an open radiant warmer, and it has this UV light that shines down. You want to make sure that you cover the genitals and they get their little baby sunglasses, because obviously that's going to be very bright. So that would be more of your traditional management. The one on the far right, I always think about little baby glowworms. There used to be this toy that you could squeeze its belly and it would light up like that. But those wrap around the baby so the baby can be in mom's room. So if they're doing the one on the left, that's usually done in the nursery. If they're doing the one on the right, it does allow them to stay at the room with mom, and they don't have to wear the sunglasses for that. We also want to make sure that they are voiding and stooling properly, because that's how the body gets rid of that extra bilirubin, is to have stools. So making sure that we are checking their intake and output is going to be very beneficial as well. The picture on the top shows before phototherapy, which is what this glow or UV light therapy is called, and then after, how they have a more normal color appearance and not that yellow discoloration anymore. Hypoglycemia. So I'm going to talk about this for a couple reasons. So I want to first go over what babies are at high risk for hypoglycemia. So the ones that are at high risk are going to be your babies born to a gestational diabetic mom and your premature babies. and the ones that are very large. So your gestational diabetic moms tend to have large babies. So I'm going to give you 3 different instances that you should be very mindful of hypoglycemia. Prematurity, babies born to gestational diabetic moms, and big babies, which your medical term for that is macrosomia. So macrosomia, macrosomia. Most neonates that have hypoglycemia are initially going to be asymptomatic, but once they become symptomatic, they are usually pretty symptomatic, so we want to make sure that we're checking it. So some of the signs and symptoms that you could see that would be a little bit different than what you would see in an adult that has hypoglycemia is going to be apnea, cyanosis. Hypotonia means that they're not very, they don't have good reflexes. They become very flaccid or floppy. We call them floppy babies because they don't have much tone. They're not going to feed well, which is going to further cause an issue because we need to get them to feed to get the sugar back up. They can have seizures, irritability, they can be very lethargic, and they usually have a very high-pitched cry. Now, just like adults, they can also get jittery. So if you're starting to see tremors in a baby, one thing you should do is check the blood sugar because chances are they could potentially have some hypoglycemia, and then they can go into some respiratory issues as well. The thing that is different with your babies is that their glucose level normally is much lower than ours. So for an adult patient, we consider about 70 to 110 normal. For a baby, as long as they are not less than 40, they're not considered hypoglycemic. So less than 40, even some say less than 35, but we're going to use less than 40 for our reading. So if they are less than 40, that is considered hypoglycemia. So depending on what their level is and what symptoms they're presenting with will determine what our plan of care will be. So let's say you assess the baby and the glucose level was 38, but they were still alert and it was just a routine check, then feeding the baby and rechecking it is completely appropriate. However, if they were 25 and they were extremely symptomatic, we may have to do some glucose that's administered by the healthcare provider or by the nurse before, instead of letting them eat because they're already symptomatic. So feeding is going to be the biggest thing, feeding them on demand, feeding them frequently so that we don't get into any hypoglycemia issues. But just remember your cutoff is going to be less than 40. So less than 40, asymptomatic, feed them and recheck it. If they are very symptomatic, then they may even require that they are getting some glucose by the nurse. Just like we talked about with your postpartum assessment being hugely important for your postpartum questions on a test, for your infants, being able to recognize if they are developing respiratory distress is a hugely important component of what you will see on test questions. So in your infant, they are going to have some symptoms that would be just the same as your adult patients as far as respiratory distress, but they're also going to have some extra ones that you need to be mindful of. So they will typically have an increased respiratory rate. We've already said that their normal respiratory rate is 30 to 60, so this would be above 60. They will have nasal flaring. They can have something called retractions, which you can see in an adult, but if you've ever seen it in a kid or an infant, it is pretty pronounced. So take a couple minutes and Google retractions in a newborn. It's pretty devastating, but it's basically like that it's almost like their chest sinks in with respirations instead of expanding. So it is a huge sign of respiratory distress. They will also have decreased oxygenation, saturation levels. They can have cyanosis, but the weird one is grunting. So parents always think, oh, they're grunting and that's so cute, but that's really not cute with a baby. If they are grunting, then they are trying to change pressure to compensate and to bring more air in. So, if they grunt every once in a while, that's not a big deal. But if they're grunting with every respiration that they have, they are in distress, and that needs to be taken care of and some interventions taken care of there. Remember the acrocyanosis, the little blue hands and feet, not problematic. So this is going to be cyanosis of the trunk, bluish discoloration around the mouth and nose. That's going to be what we're talking about when we talk about cyanosis, not the acrocyanosis. Feeding method, breastfeeding versus non-breastfeeding. I just want to hit the high points on this. I'm going to do non-breastfeeding first. So before a parent goes home, if they are non-breastfeeding, we kind of spoil them in the hospital. They have this little little bitty bottles. It's already sterile. They just screw a nipple on. So part of the discharge teaching before we send these moms home, moms and dads home, is going to be to make sure they understand how to mix formula or how to safely administer that. If they're putting too much water in it, then the baby's not getting the nutritional content. If they're putting too little water in it, that can cause GI issues. So it's important that they know how to adequately mix the formula, whether they use powder or ready to feed. So we need to kind of go over that with them. We also need to make sure that they understand the position to put the baby in when they're feeding to prevent them from sucking in a lot of air that will cause their stomach to be upset and for them to get very colicky. So positioning is going to be very important. Your babies that are bottle fed do tend to go a little bit longer in between feeds because they are going to typically they're going to have to process that a little bit more. Breast milk's kind of already processed for them. So your non-breastfeeding babies are going to usually eat about every 3 to 4 hours. So those are kind of the big things with your non-breastfeeding babies. For your breastfeeding babies, those babies eat much more frequently. They usually eat every 1 to 2 hours. Their stool looks different. It almost looks a little bit like mustard seeds, has a really weird yellow appearance to it. That's completely normal. And their stools do tend to be a little bit more loose, whereas with your non-breastfeeding, they tend to have more issues with constipation. We do go ahead and teach our moms the different positions that you can use for breastfeeding. So you'll see 4 listed on the left-hand side picture there. Cradle and cross cradle are probably the most commonly used in the hospital. My personal favorite is the football hold. So if you think about the guy holding for the Heisman Trophy, that statue, it's kind of positioning the baby that way. That's a very good positioning for your C-section moms because they can sit up in the bed and the baby's not laying on their abdomen where it's really tender. We don't usually use the side lying position in the hospital, but it's a fantastic position at home for nighttime feeds. Once they've got a very good established latch and the baby's breastfeeding properly, side lying is a very good one for them to transition to for nighttime feeds. Of course, with SIDS prevention, meaning that when they're done eating, they will be placed back on their back in the bassinet or whatever, the baby bed, whatever they're using for that. So positioning is very important. So breastfeeding are going to feed on demand every 1 to 2 hours. We're going to need to teach positions to the mom. A lot of moms really do worry about whether or not the baby is getting the nutrition that they need. So in the hospital, if that's a real big concern, or even if they've gone home, we do have lactation consultants and they can actually come in on an outpatient basis. And what we can offer them is we have scales that are very, very sensitive to weight changes. And so we can weigh the baby, let them breastfeed, and then weigh the baby again. And we can tell pretty closely how many ounces they're getting with breast milk. As a general rule, we tell the parents if they're gaining weight, they're peeing and they're pooping, they're getting enough nutrition. Parents often want to overfeed babies just because they think they should be feeding more, but their stomachs are actually really tiny at birth. They don't need tons of food. With your breastfeeding, we also need to make sure that we teach our moms that they're going to go through stages. So that initial stage they're going to go through is going to be colostrum. It kind of looks like honey colored, but it has a lot of antibodies in it. So we want to make sure that they do offer that to the baby. There's some cultures that don't like to give the colostrum, but we do want to promote that as much as possible because that's what carries the antibodies. And then they will get their mature milk, which looks more like traditional milk. If you have a mom that's pumping her milk for whatever reason because the baby's not taking it, or maybe she's just trying to get some extra in the freezer, when they pump it, it does look like it has a slightly blue tint to it. That's completely normal. And if they leave it sitting there for a little bit, it's going to settle out to have what looks like cream on the top, but the fat content will be on the top and the milk will be on the bottom. So that's also extremely normal, nothing for them to worry about. Some cues that the baby is hungry. So this is a good little picture or supplement to give the mom so she can kind of know, because once they get to the point where they are crying, you're going to have to calm them down before they're actually going to be able to feed, whether they're breastfeed or bottle feeding. So mouth opening, having a rooting reflex. So like if you scratch their cheeks, if you look at that top right one, if you were to stroke their cheek, a baby that's hungry will turn their head towards that and open their mouth. That's called a rooting reflex. It's one of the neurological reflexes that we test the baby for is a rooting reflex. So those are kind of just little cues that tells us, oh, this baby's hungry and we need to feed them. For your boy babies, we also want to teach them or ask them about circumcisions. It is not required that they have their baby circumcised, and that's totally fine if they don't want to. But if they are, then there's usually two main ways that we do that. And I know these pictures are kind of graphic, but it gets the point across. So the two main ways that you would see used is the Gomco, which is shown on the top left, and the Plastibell, which is the bottom left. And your care for those are going to be different. So with the Gomco, when they are finished with that procedure, obviously we do need a consent for this. And if you remember from your 113 lecture, if they have hypospadias, then we do not want to circumcise them because they may actually need that extra foreskin for the repair of that. So a consent form signed. If they have hypospadias, we do not want to circumcise them because they will probably need that for some of the reconstructive surgery. But assuming that we've got a consent and everything's good, then we need to make sure that in the post care of this that we do what we need to for the baby. So for the Gomco, which is the picture in the middle, the penis is going to come back and it's going to look very raw. So for that baby, we want to make sure that we coat the penis and the diaper where the penis is going to hit the diaper with Vaseline so that it doesn't stick. Because you can imagine that's a very tender area. And if it sticks to that diaper and we pull the diaper off, it can be very traumatic to the baby. So for the Gomco method, we will need to use Vaseline to prevent it adhering to the diaper. With the Plastibell, you do not have to use Vaseline because it is not raw looking and it has a little plastic ring, and that plastic ring will just fall off. So the parents don't need to do anything related to that. It'll just fall off. We do need to make sure, regardless of the method that was used, that the baby is voiding, because that's going to be a stepping stone or a milestone before we can send them home, is that everything's working post-circumcision. If the mom is not circumcising, we need to make sure that we educate the parents on how to clean the penis. So when we're doing that, as far as non-circumcised babies, when they do their bath, they're going to need to retract the foreskin and clean it. But when they're finished and everything's dried off, they need to retract the foreskin back up. So they don't need to leave it retracted down on the shaft of the penis, because that can cause swelling, and that skin can actually get stuck in that position, which can cause a lot of issues. So they do need to retract the foreskin on the shaft to clean the penis, but then replace it back to what position it was in before they retracted it back. A lot of your newborn care is going to be education, education, education. So we're going to kind of go over these as well. So we will teach the patient how to swaddle the baby. Swaddling is going to be wrapping them tightly in a blanket, because remember, in utero they were in a nice, secure, warm environment, and so that is usually very soothing to a baby to have them swaddled. However, if they're a thumb sucker, make sure you leave a hand out, or it's going to drive them crazy trying to work that hand out of that tight blanket to get their thumb to their mouth. So if they're a thumb sucker, leave a hand out, but if they're not, then you can tuck them in kind of snug, and they usually go right to sleep. Helps to make them feel secure, and it also helps to keep them warm. Your baby needs to have a hat on to prevent heat loss through the head, because they can go into cold stress, and if they drop their body temperature, they're going to tend to develop respiratory distress as well. We're going to teach the patients how to use the bulb syringe. So the bulb syringe is that big green bulb thing that has a skinny end. Most every parent has those. I probably should have put a picture on here, but I'll try to, if you don't know what a bulb syringe is, then Google that so you can see what a picture looks like. We are going to teach the parents how to use that. So they're going to need to depress the little bulb part away from the baby's face, because if we did that in their face, it's going to cause them to take a deep breath and suck in what we were trying to get out. And then you're also always going to suction the mouth and then the nose. So your babies are obligate nose breathers at this age, and so we want to suction the mouth, because if we suction the nose first, they're going to take a deep breath in and it's going to suck down through their airway. So mouth first, then nose on the bulb syringe. We already talked about feeding schedule of breastfeeding versus non-breastfeeding. We're going to make sure that the parents, one, have a car seat, and two, can adequately place the baby in it and into the car properly. So what your hospitals do to accommodate this is they make whoever's going to be helping them, they make them bring the car seat to the bedside. We watch them place the baby in the car seat and make sure the straps are the appropriate tightness and height and all those things are adequate. And then we also make the parents put the baby in the car and make sure they are secure in the car. So that's what we do as far as car seats. If we identify someone that does not have a car seat, there are resources that we have that we can get them car seats. They can't leave the hospital without a car seat. So we also want to stress the importance of well baby checkups, because a lot of times those are going to be when you're going to pick up on issues that may be occurring that maybe the parent hasn't picked up on yet. So we want to encourage well baby checkups, and we typically go ahead and schedule their first well baby checkup before they're discharged from the hospital. There will be several newborn screenings that we do. The first one is the PKU test. PKU is one thing, but it kind of is evolved into testing for a lot of different things. So we still call it the PKU test, but it actually tests for a wide range of metabolic diseases that the baby could have that are treatable if we knew they had them, but that can be devastating if we don't know. So it is state mandated. It has to be done. Can't be done before 24 hours postpartum or post-delivery. So it has to be born at 24 hours or greater, has to be done at 24 hours or greater. And it's going to test for metabolic diseases. It also tests for congenital hypothyroidism. There's a whole wide range of things. So typically what we tell our parents, it's going to be a heel stick. It's sent off to a lab. The results will be sent to the pediatrician. If you never hear anything back from your PKU test, that's fantastic. If there's an abnormality, they will contact the parents and, for follow-up and that kind of thing. We also do a newborn hearing screen, which is not diagnostic of hearing loss, but does give us an indication whether or not they could potentially have hearing issues. So that's done before they go home from the hospital. If if everything's fine with the hearing screen, there's no follow-up. But if it was abnormal or there was a high likelihood that there was a hearing issue, they will schedule them for follow-up to evaluate that a little bit more closely. The CCHD is the congenital heart defect screening that we now do. So it's a pretty easy screening tool. It involves a couple different things, but also checking blood pressure in an arm and a leg on at least 1 or 2 occasions. So that just kind of tells us or gives us some indication if there is a potential congenital heart defect, which you will also learn more about in 211 next semester. If that screening comes back positive, then they will do follow-up, which is usually an echo to look at the function of the heart to see if there's an abnormality within the heart itself. So that's just a routine screening that we do. We're also going to teach the parents about cord care. So when we look at cord care, we used to do alcohol. They really don't do that anymore. So typically what we want to tell our parents about cord care is they need to keep that cord nice and dry and clean and assess it for signs of infection. So typically with each diaper change, they need to be assessing that area. Some of your hospitals may still use alcohol where they kind of clean around where it attaches to the skin with alcohol, which helps promote drying but also helps prevent infection, but most of your hospitals don't do that anymore. They do not need to submerge the baby into a bath until that cord falls off, which usually happens about 1 to 2 weeks post-delivery. So until then, they're going to need to do sponge baths so that cord can get dry and fall off. They do, right post-delivery, they put a little cord clamp on there. As soon as the cord is dry, that clamp can come off, but no tub baths until the cord itself falls off. Circumcision care we've already been over. Vaccination schedule I'm not asking you to memorize, but a couple things that we did talk about was the pertussis vaccine and how that's going to help to protect the baby. I'm not going to ask you test questions on at 3 months the baby should have this vaccination. The ones we've talked about were pertussis for the mom to help protect the baby, and we also mentioned the hepatitis B. Outside of that, you don't need to know anything right now for that. Daily care, how to change diapers, how to wipe little girls front to back, that they should be peeing and pooping, just normal activity. They're going to sleep a lot, but they shouldn't be lethargic, those type things. So all that's going to be included in your teaching. The screening results will be given to the parents for the congenital heart defect screening and the hearing screening. The PKU is a send-out lab, so that's going to take a while to hear anything back. We're also going to teach them about SIDS prevention, putting the baby on the back, making sure they have a firm mattress, avoiding clutter, no co-sleeping, making sure they're not smoking, all those things, making sure the baby's not overheating. So all of those things are very important to teach, and that kind of goes back to your 113 content. As far as danger signs with your baby, a lot of these are kind of self-explanatory, but when we look at danger signs, if they start running a fever greater than 100.4, or they have a low temperature less than 97 axillary, that needs to be reported. So fever greater than 100.4 or a low temperature less than 97. If they have rapid breathing greater than 60 breaths per minute. If they have any discoloration of their face, tongue, lips, so if they become cyanotic or having some paleness. If they are jittery or have shaking all over their body, that could be low blood sugar. It could also be seizure activity. If they're not eating, if they're vomiting large amounts of feedings, if they have a rash, if they're unconsolable and excessively crying, that needs to be reported. If they're not stooling or voiding, if they're constipated or having diarrhea, if they're floppy, so if they have hypotonia, so if they're floppy, they need to report that. And then, of course, if they have yellowing of their skin or the whites of their eyes, that may be some recurrent jaundice that we need to deal with as well. And that is it for your newborn PowerPoint. So that covers all the content for your reproductive. I do understand that this is tons and tons of new content for you guys, and we're kind of shoving it at you. So do remember that you have these resources that you can go back to. I do hope that everybody has worked through all 4 of these videos before they come to the afternoon session. It will make it a lot more productive for you, because then we can use that time applying. So I will see you guys in the afternoon session, and I hope you have a good rest of the day.